I'm Julie Richardson. I'm a paediatric intensivist at Belfast Children's Hospital, and I have the pleasure of talking to you about the sick cardiac child today. I think for most of us, when we're told that there is a child down in ED who has cyanotic heart disease, we feel a bit like this. So absolute horror and terror comes into our hearts, even though we may not show it unless you're actually a cardiologist. And even them, I think sometimes feel a bit nervous. So I'm going to run through a few cases, a common scenario, and a couple of more unusual cases at the moment, and hopefully just build your confidence a little. So baby A, 4-week-old, collapses, is apneic. The pH is 6.8, the CO2 is 8, the lactate's 5, the glucose is 2. So what are you thinking? Well, because I'm doing a cardiac talk, you're thinking this is likely to be a duct-dependent lesion, probably coarctation of the aorta. And in this case, you're absolutely right. And this is a picture just to remind you what that looks like. Typical presentations about 4 weeks of age when the duct closes and then the baby's reliant on the aorta, which is fixed. However, babies do not come with a label. They do not come saying I'm a cardiac baby. They come collapsed and sick, and there is a differential diagnosis. Many of you are really used to this situation, but it's really important, and it's really important that you act quickly. The differential is sepsis, 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 obviously cardiac disease. It could be metabolic, it could be surgical, such as a volvulus, or it could unfortunately sometimes be a non-accidental injury. Your history and your examination are really important in trying to break that down. The fact that this child had a low sugar might push you in the direction of it being metabolic, but also that happens in sepsis and in sick children. You might, on examination, find that the pulses are weak. Again, unfortunately, that is found in sepsis and in just very sick children. So it can be difficult, although the books make it very clear, it can be difficult clinical to work out what's going on. So in terms of management, you're going to do your ABCs. You're going to give some antibiotics. In this particular child, you're going to intubate them, and you're going to do that with care, which we'll talk about in a little moment. Prior to intubation, you're probably going to start some inotropes on this child, and because we are deeply concerned this child might have a coarctation, you're going to start some prostaglandin. You may start that before you've got echo. Not all hospitals have an echo facility immediately, and it's better to treat soon and stop later. You can always stop prostaglandin. So I'm now going to just talk to you a little bit about my general approach to the sick cardiac child that requires intubation. And I view it as a situation that is an impending disaster. The best approach, particularly with a cyanotic child with a complex heart, is to presume this child is likely to arrest on you. And the first question is always, do I really have to intubate them? And once that decision's made, you want the most senior person available with the most knowledge. However, you also want to be timely and not delay unnecessarily. So in terms of this, like I would with any sick child, but particularly with a cyanotic heart disease child, you need to be prepared and you need to get organised. So you're going to draw up fluids, you're going to prepare for an arrest, you're going to prepare your team for an arrest and delegate roles. You may well start an inotrope, and I usually do before I intubate a child with cyanotic heart disease in particular, so I'm thinking about a hypoplast. And I'm going to be fully prepared for a difficult intubation because of the cardiovascular status. In terms of the induction agents, I would usually use ketamine because it's cardiovascularly stable. However, in the very, very sick child, such as a hypoplast, I may not even use ketamine. I might use something like fentanyl, so enough to reduce the catecholamines and allow me to place a tube, but not to prevent an arrest. What you also have to remember, usually in a cardiac child, that the reason you're intubating them is because their cardiac output is poor, and therefore all your drugs will take longer to act. So you need to be patient and give them time to work and prepare for the worst. Magic adrenaline, something that I usually have in my pocket, or push-dose adrenaline. I would absolutely always have this with any sick child requiring intensive care, but particularly so with a child with cardiac disease. It's easy to make up. Adrenaline's found in every ED, and it's easy to give little tiny aliquots to keep you out of trouble. And hopefully if you prepare and you consider and you have your team all planned, then the seas will be calm and you will have a straightforward intubation. So moving on to another scenario. So we have a little baby come into ED who has double outlet right ventricle, TGA, pulmonary stenosis and a small RV. If you're not a cardiologist, your heart is racing and you're already worried because you're thinking, I don't even understand what that means, and it sounds awfully complicated and I can't understand which way round the blood's going. The family tells you that they have a BT shunt, which is 3.5 millimetres, and the kid's had recent diarrhoea and vomiting and has just recovered from that. On examination, the heart rate's 190. They look blue around the lips, and when the saturation monitoring's put on, it's 50%. When you listen in, you're not sure if you can hear a murmur or not. And as you will remember, shunts should have a really loud, continuous murmur, and they're not subtle in any way. So what we're worried about here is, has this child actually got a blocked shunt? These days, presentation of a blocked shunt is really uncommon because we don't use them as frequently as we used to. Lots of children get full repairs rather than a staged repair. So we're not quite as used to seeing a blocked shunt. The most common time that will happen is immediately post-op, so in the first couple of days when they're still in the intensive care. But the other time that this might happen is when they've become a bit dehydrated and got another illness. So it's something that you should think about in your differential when you've got an unwell child, and it's really important that you keep these children hydrated and don't restrict their fluids. So something like a stenotic pulmonary valve is the sort of lesion that may get a BT shunt these days. And again, just to remind you what a BT shunt does, it's just an artificial conduit from the left subclavian artery to the left PA. So what do you do if there's a blocked shunt? Well, this is absolutely an emergency. So you're going to give them some oxygen. You're going to start preparing to intubate with all the cautions that we thought about. You are going to get an echo as soon as possible. However, echoes are not terribly good at picking up clots in shunts. So even a negative echo might still not persuade you that you don't have a blocked shunt. You're going to give some volume, so you're going to give aliquots of 5 to 10 mils per kilo. You will give some phenylephrine of 10 to 30 mics per kilo. Phenylephrine, many of you will not be familiar with. It's a very potent vasoconstrictor and is very useful in this situation. You may start a little bit of inotrope, such as dopamine or adrenaline, but actually once you've got better access, what you probably need is noradrenaline. This is all to increase your systemic vascular resistance and try and persuade blood to go to the lungs. Once you are in the position of intubating this child, you're going to sedate and paralyse them. You're going to try and minimise the amount of PEEP. You're going to give them lots of oxygen as a potent pulmonary vasodilator. You're going to aim for alkalosis and also give them a little bit of magnesium to try and help and persuade any blood flow that is left to go to the lungs. At this point, you're very much hoping that you don't have an entirely blocked shunt, but a partially blocked shunt, because otherwise none of this will potentially work, depending on the anatomy. If you haven't done so already, you should absolutely be contacting cardiology and paediatric intensive care at this point. They may well suggest that you should give a heparin bolus. This is usually at a dose of 50 units per kilo and may be repeated. They may then suggest you start a heparin infusion in the order of 20 units per kilo per hour. Again, in the child that the shunt has been in situ for many weeks to months, this is unlikely to change the situation, but may prevent propagation of clot. If this is a little tiny baby in neonatal age who has still got a duct open or has potential for an open duct, you might actually be advised to start a little bit of prostaglandin, again to persuade some blood to go to the lungs. Ultimately, however, this child needs, if there's no improvement or minimal improvement, this child needs to be in definitive care centre and needs either a catheter urgently or surgery. Very occasionally TPA has been used successfully. So it's really important that you identify the problem, you act quickly, stabilise the child and speak to the specialist and get this child to the right place at the right time, or else there'll be a real disaster. And since shunts are so uncommon these days, it's not something that you would necessarily think about straight away. When you've got a blocked shunt, it's an absolute emergency. You're going to use your ABC approach. You're going to intubate early with the caution and preparation that I spoke to you about earlier. You're going to increase the SVR using your fluid bolus, phenylephrine, and then an infusion of noradrenaline. You're going to decrease your PVR using sedation and paralysis. You're going to aim for alkalosis, and you're going to use high oxygen. At that point, you're also going to attempt to stop propagation of the clot, or unlikely to be able to remove the clot, but use a heparin bolus, heparin infusion, but ultimately you need to be in a surgical centre because this child may well need surgery and a new shunt. So moving on, I am going to talk about yet another scenario which used to be very, very common, and I spent most of my SHO days running to cardiology to deal with this, but again it's something that's really uncommon these days. So baby C has tetralogy of Fallot. They've come into ED with poor feeding. They're having intermittent blue episodes, particularly bad when they cry or actually when they poo. Their SATs at the moment are 65% when you measure them. And when you listen in, there's some wheeze and auscultation and you can't hear a murmur. So what we're talking about here, and just to remind you about those of you that can't quite remember tetralogy of Fallot. So you've got a stenotic pulmonary valve, you've got a VSD. Because of that, you've got a very thickened right ventricle, and you've got an overriding aorta. And the problem here is when there's a change in PVR and SVR, suddenly you have less flow to the lungs. So a bit like the situation we talked about before. So what we have here is a spelling child. And spelling always made me think of something magical and wonderful. Unfortunately, it can be life-threatening and not at all magical, otherwise known as a hypercyanotic episode. So the first thing to do is keep calm and get prepared. So the first thing you're going to do is soothe this child. So put the baby in the mum's arms, get it cuddled, get it calm, because if it's crying and cross, you're going to struggle to get blood to the lungs. The next thing you're going to do, if that hasn't worked, is to bring the knees up to the chest, lying the baby on their back, and that increases the SVR. Then you're going to give some oxygen if they'll put up with it, and then you're going to give some morphine. Now, if you don't have IV access, it's suggested you should give IM morphine, because obviously attaining IV access is going to distress the child initially, and IM is quicker. If your child's still got SATs in the 60s or less, then you need to move on to the next stage. So you're going to keep calm and carry on. So at this point, if you haven't already, you're going to call your cardiologist in intensive care. You're going to be thinking about getting access. If you haven't already, you're going to give a fluid bolus of 10 mils per kilo and repeat that. You may give a dose of oral propranolol, which again can be repeated 15 to 20 minutes later, or you may be suggested to give an IV dose. Again, phenylephrine can be very useful in this situation, and again the dose of 10 to 30 mics per kilo in little aliquots to see if you get a response. And your aim here is to try and improve saturations and break the cycle. At any of these points, the child might suddenly look much pinker, look much happier, and you don't need to then proceed with the next step. However, if all of this has failed to work, then you're in real trouble. So you've got a child who's having a very prolonged spell, remaining very blue, the infundibular spasm hasn't relaxed, and you're struggling to get blood to the lungs. At this point, you may consider intubation and ventilation. You want to increase SVR, so you're going to run some noradrenaline. And this child, honestly, at this point, may well need an emergency shunt. So at that point, you need, again, to be in a place which can perform cardiac surgery and as soon as possible. In the meantime, giving supportive care. And then the very last child and situation I'm going to talk very briefly about is the child who comes into ED at age 13. They've recently had an upper respiratory tract infection. They've had a high temperature. They generally just haven't recovered from that. They're lethargic and not themselves. They've also complained intermittently of mild abdominal pain. Their heart rate is 160 and they have a few scattered creps on auscultation. So as you will note, the heart rate is high. There's some scattered creps. Recent chest infection, you're probably thinking about a pneumonia or lower respiratory tract infection. But as I'm doing a cardiac talk, you know I'm probably not going down that line, and I wish patients could just tell you what's wrong with them sometimes. So this child actually turns out to have a myocarditis. And the clues were the persistent tachycardia. When you do a chest x-ray, it doesn't show the pneumonia that you were expecting, but it actually shows really quite a large heart. If you're clever and been thinking ahead and thinking potentially about a heart, you may have done a troponin, which will be high. The ECG, when you do it, may show some arrhythmias. It may show some ST elevation. It may show some right ventricular, left ventricular hypertrophy. And when you do an echo, you've got perhaps a cardiomyopathy, a slightly dilated heart. In terms of myocarditis, I'm not going to go into the details of treatment. It's generally supportive. Many of them will manage without needing paediatric intensive care, but the main point of bringing this up at this point is actually to consider it in your differential diagnosis. Most children who have myocarditis initially are treated as a pneumonia or an asthmatic in the first instance, and then it's only due to failure to get better or failure of treatment or deterioration that suddenly the heart is thought about. So it's uncommon. The most common virus that causes it is enterovirus. In our population, it's usually a virus, but it's also important to think about in a child who has had oncological therapy. Treatment is supportive, diuretics are important, immunoglobulins can be helpful, as can anticoagulation, and the very worst group of children may need paediatric intensive care support and potentially mechanical support for the heart or even transplant. But we're very lucky because many children get better in the next 2 to 3 weeks. However, it's very difficult to predict which ones will get better and which won't. In terms of everything I was going to say today, that is it. My main aim of this talk is to say, remember to think about cardiac, particularly in a child who isn't getting better, particularly this winter when you've got that host of bronchiolitis coming through the door. In amongst all of those, one of them will have an undiagnosed VSD and actually be in heart failure. So if you've got a child who's not very well, who is getting worse and not following quite the path you thought, just always think, especially when you're thinking, do they need paediatric intensive care, just always think, have I got the right diagnosis? In the children with cyanotic heart disease, think about, well, do they have a shunt? Could it be blocked? In the Fallows child, know about spelling Fallows. And obviously the collapsed neonate, there's a big differential diagnosis, and cardiac is one of those. So be prepared, prepare for the worst, drop your drugs, think about what you need to do, prepare your team, discuss early with the tertiary centre, cardiology and paediatric intensive care, and get the patient to the right place. There's no point being in a centre that can't actually repair your shunt or do what you actually need. The medicine sometimes fails, and what you actually need is the surgeon. Thank you very much.